All right. Hello, everybody. Welcome to today's healthcare law webinar hosted by Liles Parker Law Office, which has also been brought to you by the Texas Association for Home Care and Hospice. Today's presentation is entitled Practical Advice for Strengthening Your In-House Home Health or Hospice Compliance Program. How will DOJ assess your compliance program? Today's presenters are our very own healthcare lawyers, Robert Liles and Paul Weidenfeld. And I'll let them tell you a little bit more about themselves. But first, I want to say one quick reminder. If you do happen to have any questions throughout this presentation, please feel free to enter them in the chat, and we will get to as many as possible at the end. So without further ado, I'll pass it over to you guys.
Thank you very much, Liz. Really appreciate it. This is Robert Liles. I'm a managing partner here at Liles Parker. And my background is, as some of you probably know, I was an assistant U.S. attorney for many years and have been in private practice for quite a while. And we represent a number of hospices and home health agencies around the country. And I was supposed to be joined with my partner, John Pierce. He had a case conflict. So I'm here with my good friend, Paul Weidenfeld. And Paul Weidenfeld is founder of Exclusion Screening, who does a lot of the screening requirements for home health and hospice all over the place. Paul is also a former assistant U.S. attorney. He was a national healthcare fraud coordinator, and he is a very experienced trial attorney. So he's going to talk to us today about how DOJ looks at your compliance plans. Hey, Paul.
Hey, Robert. Thank you for having me. I'm always happy to be participating in webinars with you.
Well, thank you. Let's start on in because we got a lot of information. Next slide.
All right, let's do it.
Now, we're here to talk about how is DOJ going to assess your compliance efforts, okay? But the fact is, you can't even get to that question without first talking about where did compliance come from? How did that pop up? For those of us who have been in healthcare for a long time, compliance plans really didn't start until 1998, and you really have to give the credit to HHS OIG. We don't always agree with them, but the fact is they were ahead of the pack when it came to compliance. And in fact, many of the approaches that they developed for compliance are now not just used in healthcare, but they've really transferred over to banking, finance, and other industries. So OIG, you really have to give them credit because they really put a lot into this. And where did they come up with it? Well, originally it came from this idea in the U.S. sentencing guidelines. There's a provision there that says, essentially, of course it's in a criminal case, but if you have systems in place to help you do the right thing for the right reasons, and you can show that, in fact, you were trying to follow those systems, you can actually get a break in a criminal case. Well, when OIG developed its approach to compliance, it took that and expanded upon that idea. And that's really kind of how we got here today.
Well, and part of this is the idea, it does go back a little bit historically in the sense that the medical profession resisted, as you well know, even Medicare at its inception. They thought they didn't want the government to interfere with healthcare. They would mess up the billing. They would mess up all kinds of things.
And that's proven to be true.
As it has. And so, although it's proven to be lucrative for them as well. So there's it's both ends. But so the idea has been, we can police ourselves, we will police ourselves. And so the idea of self-policing kind of was going around. And I think what the OIG did said, well, if you're gonna do self-policing, then let's have some structure to that. Let's not just say, oh, we're looking at everything. Let's kind of identify what you're supposed to be looking at, how you're supposed to do it, and let's have a system. Let's not just say, oh, you're policing yourselves and we're good with that. And I think that creating structure to the idea of compliance is a critical step. And as you say, in 1998, I think they kind of started taking that step forward.
They did. And I would like to point out that home health and hospice agencies were two of the very first areas that they were concerned about.
Absolutely.
So this is important because, it's, 1998, 1999. That means that for more than 25 years, home health and hospice agencies have had guidance that they're supposed to be looking at, that they're supposed to be trying to put in place to help them stay within the four corners of the law.
Well, and home health and hospice have been on the radar for a long time for reasons, because they involve billing and they involve patients, and those are the two key concerns. I was trying a case in 1998 about home health. Home health was very high on the radar of government in the late 90s.
I know what case you're talking about. That was a case involving Terra.
The case involving, yes, they bought a home that they labeled Terra, and they would play the anthem to
Gone with the Wind.
The Gone with the Wind when they would drive up to the gate and so on and so forth. But it was very much on the radar, and so the industry had earned a place high up on the
Which is
list.
not a good list.
Not a great place to be, and it's no longer at the top of that list.
That's right. There are other areas that are even more problematic today, but they are still, especially with all the PPEO audits and the TPE audits and the rest of it, home health and hospice are still under the microscope. Next slide. Now, these are just two excerpts from the guidance that was issued in 1998 and 1999. And one of the reasons why I wanted to bring this out is that when OIG came up with this guidance, it was meant to be a guidance that you could modify, that you could revise so that it fit your needs for your organization, whether it's a small home health or a small hospice or a multi-state organization.
Absolutely, Robert. That has always focused on the fact that it is not a one-size-fits-all kind of situation. That you can't go to the internet and find a form and say, oh, there's my compliance plan. Yep. Compliance is individual and focused on the needs and risks of your agency.
Right. And as we have seen over the years, a compliance plan, for those of you who all of you should have one, but it really is a living, breathing document.
Right.
It changes all the time. The risk areas that you have to be concerned about as an owner or an administrator of a home health agency or a hospice agency, those are ever changing as well. There are some core risk areas that seem to stay no matter what, spring, summer, winter, fall, doesn't matter. Those are always going to be a problem you have to watch out for. But there are some new things that pop up as well.
I have heard you say that your favorite kind of compliance plan is the one that they pull off the shelf, that's dog-eared, that has additions and pull-outs and stuff, because it's truly living and breathing.
That's exactly right. Versus if they pull it out and they crack it open for you, and it looks like it's brand spanking new.
And they pull off the cellophane or something.
That's a real problem. That's a real problem. Next slide. All right. So let's just kind of talk about, what are some of the benefits of having a compliance plan?
All right. Let's do that. So first of all, it creates the structure of how you're going to approach your patients, your billing, everything about it. It sets out, these are the things we will do, these are the things we won't do. It's tailored to your organization, to the size of your organization, to the specific risks that you have in your organization.
And the payers that you accept.
And the payers that you accept. And so it's not like a check the box, these are the things we do, but it kind of defines who you are and what you do, I would say.
I agree completely. Next slide. Now, it's a proactive approach. It's evidence of good faith. At this time, we're talking about pre Affordable Care Act. Okay. Was there a law? Was there a statute that says you must have a compliance plan?
No, these were compliance guidances that were all being issued in the
all voluntary.
Guidance being, not mandatory.
Yes. But I will tell you that even though it was voluntary or considered to be voluntary, prosecutors will look at this and they would say, but you've had this guidance out there that is specifically supposed to cover Medicare and Medicaid and other federal health benefit programs. You've had it available to you for 15 years, and you're not following that guidance. I understand it's not a law, but don't try to tell me that it was an accident that you made these mistakes.
Right. And this is the flip side of the benefits of having a good, strong compliance plan. On the one hand, it tells you, you know what to do, you know the right thing, you know how to operate your business, and you're on good footing. On the other hand, the flip side is, if there is a mistake, if there is a problem, because, you know, people are human and there are problems, now you have something to show, you know, oh, you can see where it went wrong, and you get credit for that. So it helps you on organizing and structuring yourself, but it also helps you once you have a problem.
It does. It does. Because even with the best compliance plan and the best efforts to comply with that compliance plan, you're still going to have mistakes.
Stuff happens.
It does. And you know, when I was a prosecutor, I didn't expect healthcare providers to be perfect, but I did expect them to try.
That was fair.
Next slide. Okay. So, you know, this is really kind of goes to the point that you made earlier about reaching up on the shelf and pulling down something that is brand new and it still has a saran wrap on it or whatever it is. This is not just a matter of check the box. We've got a compliance plan, so we're okay. If anybody shows up and asks about it, it's up here in the closet with the old yellow pages.
Right. That's not what we're about. No, it's got to be, you know, and you've seen it, right? And if you go on the internet, they'll say, oh, we'll sell you a compliance plan for X number of dollars or this or that. Yep. That's nothing. That does not help you.
That's true. Just because you have the plan, you have to implement it. You have to do a self-assessment to determine what are the specific risk areas that your organization has. For instance, not all home health agencies or hospices take Medicare managed care, right? Or I'm sorry, Medicaid managed care. You know, there may be some plans that they just don't take. Right. Well, you know, there are certain risks that you have with on the home health side with managed care or with Advantage plans. You know, you may have pre-authorization requirements under those types of organizations, payers, that you don't have under traditional Medicare.
You have different relationships with vendors. You have different types of relationships with how patients come in. What you do is you acknowledge your risk areas and then you do what you call a gap analysis, right? Which is simply what, Robert?
It's really where you sit down and you look at the federal and state requirements that you have to meet, and then you make sure that in fact you are complying with those requirements. And
the gap.
And to the extent that you're not meeting them, that's the gap in a gap analysis. That's right.
Not talking about generally accounting principles.
No,
different gap.
Yeah, and you know, when it comes to specific dates of service and the rest of it, you know, were the services actually provided? Were they properly documented? You know, how does each payer require that you reflect certain documentation? Were they medically necessary? Were they properly coded? Were they properly billed? And the one everybody forgets that you and I've had 2 cases on so far, were you actually paid appropriately? That's something that has popped up lately that AUSAs are making a field day on, because even though the documentation was good, it was medically necessary, it was coded right, it was billed right, they were reimbursed wrong because something happened in the clearinghouse. And who do they hold responsible for that?
The provider. And we have seen many cases actually, and it's not unusual that you don't, you know, when the money comes in or the funds get paid and they go through the clearinghouse, it's hard to see you've got how many payers. I mean, it could be 15, 20 different payers. They all pay a different amount. And if it's wrong, it's hard to see that. You've got to actually audit your financials in terms of, not just, you know, in terms of the payers, because we have seen at least a handful of cases where the clearinghouse attributed it to the wrong party and didn't let the providers know, and the providers got, well,
They got too much money.
They got too much money.
And when it comes time to trying to explain that, the AUSA said, well, why weren't you doing like a 360 audit? Why weren't you looking at this documentation, not just from day one when you provided the services, but until you actually got paid and checking to make sure you were paid the right amount?
And so many people will balance the claims that they make on with the services they provided, but they don't take that last step and see what actually they got paid. Anyway.
Very interesting how those cases are starting to shake out, but that's what the government's doing. Next slide. So in the very beginning, going back to 98 and 99, and really taking it up through 2008, when they were starting to issue these industry or provider-specific compliance program guidance sets in the Federal Register. While they're all different because they have different risk issues, they could all, the OIG did a wonderful job of really kind of setting up 7 different components or elements or silos of the this is what constitutes an effective compliance plan.
Right.
Okay.
Now those 7 elements, actually, I one time Googled 7 elements of the compliance plan,
yep,
and I found like 7 different versions. So does that make it 49 different? I don't know. But they're not. They always, at the end of the day, they cover the same areas.
They really do.
They sometimes call them differently. So in 1998, what they were using as the 7 elements were slightly different than on the next slide. For instance, we'll see that they call them slightly different. And then again in 2023, they call them a slightly different.
So what happened in 1998 then, they had these 7 elements conducting internal monitoring and auditing. And personally, I think that is the key to compliance. That out of all the 7 elements, they're all important, but I think that is the most important. You have to periodically go back, check what you've been doing, make sure that it actually qualifies for coverage and payment. The other elements, just real quick, implementing compliance and organizational standards, designating a compliance officer or compliance contact, conducting appropriate training and education, responding to violations, and enforcing disciplinary standards. Those were the core 7 components of that entire group of compliance program guidance that came out from 1998 to 2008.
If we slip to the next slide, there's one thing, Robert, I totally agree with you with respect to it's all about auditing, because auditing tells you you take all these 7 elements and auditing tells you if you're actually complying with them. It tells you if you're billing properly and so forth. But I think that the other element, which is recognized in 2019 and not specifically identified, is the screening and evaluation of your employees, physicians, and vendors.
Yes, and before we talk about that, let's kind of talk about what happened in 2019. What happened was the folks at OIG, they worked very closely with the folks at the Healthcare Compliance Association, and they actually sat down and had a roundtable, and they said, these are our 7 elements that we've had now for 1998 to 2019, so that's almost more than 20 years. This is what we've been going on. Do we need to tweak these? Now that we've had 20 years of experience, do we need to tweak these in any way? And the slides that we have here, these 7 elements or components that we have now, those are what the group came up with, HCCA and OIG together.
Right.
And I'm sorry, no, let me get back. One of the big changes, though, was they actually focused for the first time and made a separate element for screening.
Well, the screening and evaluation of their employees, vendors, and contractors. Now, obviously, I'm not here to tout exclusion screening. We do exclusion screening. There's other kinds of screening as well. I think the significance of this element is that, in my view, and I think you'll agree with me, that almost all of your risk in any healthcare provider's organization evolves from your employees. And the people that you hire. It's
all about the people.
And the people you do business with.
Yep.
And so that's why I think that, if you think of your risk, wrongful billing, someone's going to do that. Harm to patients, someone's going to harm. Wrong, and everything, is your OSHA. All of your elements come down to the people that you hire or that do business with. And I think that that's just really critical. And I think between that and auditing, you've got it covered.
And that reminds me, I always say, Mama was the first compliance officer, right? She always told us, you're judged by the company you keep. And when it comes to home health and hospice, we're going to do a long trip here today over the next hour, but we're going to end up on that issue because the single significant risk issue for home health and hospice today is the same as it was 10 years ago, and that's kickbacks, okay, and business relationships, okay? So Mama was right. Don't hang around folks that are going to get you in trouble. Next slide. All right, so let's talk about some of these risk areas, okay? Paul, we're going to start out on this slide. We're going to start out, first of all, just talking about the home health risk areas. Look at these, guys. These are risk areas, by the way, that were first identified in 1998.
So, Robert.
Okay, and they're still significant today. Homebound status, my God, that just never goes away.
So let's take one step back and then we'll go forward again.
Okay, all right.
So when you're in identifying your risk areas, this is the beginning to building your compliance plan.
That's right. These are the core risk areas. The ones I have here listed are the core risk areas that OIG has identified, but you need to look at your organization and add to or subtract based on the specific risks that your company has.
So homebound status.
That's a big one.
Obviously.
That's a big one.
And it always has been.
Yeah, it has been. Face-to-face problems, those are always been there. Here's yours. Improper employment of excluded individuals. Guys, in my opinion, that is the single most misunderstood and underappreciated risk area of every home health and hospice on the phone right now. And that's because you're not properly screening your folks. Now, we're talking today to our friends in Texas, okay? Well, Texas is very special. Of course, it's very special in my heart because I'm a Texan, 6th generation. But I will tell you, it's especially important in Texas because under the Texas Medicaid Participation Agreement, you have to screen not just your employees, agents, and vendors against the LEIE and the Texas Medicaid exclusion list. You have to screen them against all state exclusion lists.
You have to certify that you've done that.
And that's right.
Under penalty of perjury.
And why did Martha Stewart go to jail? It wasn't for insider trading. It was because she lied to the government. Okay? That's what got her in trouble. This is why it's so important. You have to use a company because it's physically impossible for a home health agency or a hospice to actually screen your own people against 44 state Medicaid databases, the LEIE, the GSA SAM, and depending on the contract, maybe even the OFAC list. It's just not possible. So some of these other things that we need to worry about here: not meeting medical necessity requirements, violations of Stark, billing for substandard care. I'm so glad to have you here to do this presentation with me because Paul was one of the very first attorneys in the country to go after substandard care prosecutions.
I did. Failure of care, we called it. Now, of course, that everybody acts like that's always been there. No, it wasn't there until Paul and a couple other folks, Jim Sheehan up in Philadelphia and a couple others really kind of went out on a limb and said, yeah, you're providing the cases, or you're providing the care, but it's not sufficient to qualify for billing and coverage, and it doesn't really meet the patient's needs. No, that's right. And they used to call it, well, that's a quality of care case, that's a civil matter, and in my view, it wasn't. And now in the view of many prosecutors, it isn't. It's, are you actually providing the service? Are you doing it are you doing it properly? Is it appropriate?
That's right.
Evaluate that. And documentation too, Robert. Haven't you seen in your practice so many instances where the service was in fact provided? You have no question about it. But the documentation is, lousy.
It is. And this especially pops up, guys, with our hospice friends, okay? Because depending on your jurisdiction, you very well may have, a handful of LCDs covering different terminal diagnoses. Sometimes they put all of them into one LCD. Sometimes they have separate guidance, separate LCDs for the terminal diagnosis. If you don't meet the documentation requirements to qualify for coverage and payment for that diagnosis, they will deny those claims.
And so you really need to see what you need. You can't just put CPT or diagnosis codes,
Or just rely on some doctor that says this person needs to be placed on hospice.
Right.
Why?
Right.
And do they meet the requirements to be placed on hospice? Okay.
Yep.
So documentation is especially important. Now, one thing that let me see here. If it's got to be here somewhere. Inducements, improper inducements, kickbacks, guys. This is really, really important. Business practices that are perfectly legal in other industries are often illegal in healthcare. For instance, you can, many home health agencies in Texas have gotten in trouble because they have hired people to do marketing for them. Now, how do we reward people for good work in America?
We typically try to pay them.
We try to pay them based on their success.
Right.
Which means, okay, my marketing company is going to go out and we're gonna gin up a bunch of referrals for your home health or hospice agency, and how about you give us $500 for each one that we succeed? That's an all-American marketing plan if I ever heard one, but it's also illegal, okay, because it does not meet the safe harbors under the anti-kickback statute, because you're reimbursing people, you're paying people that in a fashion that varies by value or volume. That's if they're independent contractors, okay?
I think that the real, since we're, we could do a whole thing on
just on that issue,
on this issue alone,
because there's 46 different safe harbors,
of which I don't understand 42 of them, But the thing is that when you're developing your marketing plan, because you've got to have a marketing plan.
Yes.
Well, when you develop it, you've got to develop with a lawyer. You got to make sure that it really is okay. It may seem okay to you, and people may say, that's what we do, so it really is okay. Just get the stamp of approval. Just make sure someone outside reviews it, and it's okay.
And there are very different rules if someone is a bona fide employee versus an independent contractor.
Exactly.
But I've unfortunately worked on cases where the client truly believed that this person was a bona fide employee. They were taking out taxes, they were W-2, the whole 9 yards. There are special indicia that the Supreme Court has recognized that says these are the requirements that you need in order for it to be a bona fide employee relationship.
And to, in simple terms, from my view, if you're having to go through those things and see if you fit here and fit here, it's probably going to be problematic.
You need to get, it really is something, guys. This is very important. You need to get a lawyer. You don't have to hire us, but you need to get a healthcare lawyer, not the lawyer who handled the second divorce for your medical director, okay, but a healthcare lawyer to do these analysis and give you good guidance on, are we square with applicable statutes?
I think the other thing on relationships is the relationships with your medical directors, Robert.
Oh, that's another huge, huge risk area.
Because doctors just, no matter what they provide, they are almost universally, there are some that, about keeping records of what they've done in support of the agency in the context of their medical directorship.
Now, just to be clear, is it against the law for a medical director who we're paying, let's say, $2,000 a month? Okay. Is it against the law for that medical director to make referrals to that agency?
No, absolutely not.
But, okay,
yep.
If you're paying this guy $2,000 a month, it can't be a situation where, oh, well, we're going to meet at the local steakhouse once a month and I'm going to give him a check. He's got to provide services at fair market value, and he's got to properly document them. And that's where these cases fall apart, because when the government comes in and they want to see the documentation for what the medical director's been doing, this person that's sending you referrals, okay, and the documentation isn't there, then the government concludes, understandably, the only reason you're paying them $2,000 a month is really for the referrals.
Robert, how many times have you heard when you've gone to a client and said, okay, that's great, and they say, we love the medical director. He's there all the time. He's providing all these extra services. He's reviewing records. He's making sure, he's doing sort of these kind of odd and all these functions. He's critical. And then you say, that's great, So you ask the doctor, where are the records? And he goes, well, I'd have to go to my calendar to see when I was there.
Yeah.
Okay, but that just says what you were there. Did you also see patients when you were there? Well, yeah. In other words,
That's a huge risk, and unfortunately, the bad practices of your medical directors are putting you at risk. Okay. All right. Next slide. Let's go on to like you said, we could spend a whole hour talking just about those particular issues. Maybe we should, but not today. So now let's look at the hospice risk areas, guys. This has turned into, even though it was identified in '99, uniform consent to elect the Medicare hospice benefit, it's been a big deal the last 5 years, because when they're doing audits now, before they never asked for that document. Okay, now they keep asking for it, and sometimes you can't find it. And the problem is, when someone, of course, elects hospice, they give up curative treatment. That's the problem. So, the folks, the enforcement folks, want to know that when you're bringing on hospice patients, they want to make sure that these people have been properly educated as to what this means, because they're giving a lot up when they sign up for hospice.
And we know there's sensitivity with broaching this subject.
It is. Right?
And and so a lot of times we'll get mom or dad or somebody to agree, okay, I'll go in. But they don't want to get them to sign anything. You don't want to actually formalize that. I've got them to agree, that's good enough, we're good to go. They have accepted it, we're in hospice. That's really important. But you got to take that next step and formalize it.
That's right.
I understand.
Okay, the next one here, and we're not going to go over all of them, but some of these I do want to talk about. Admitting patients to hospice care who are not terminally ill. That's a tough one, because when you admit them to hospice, what's the expectation that they're going to live?
6 months.
6 months. But who knows? Maybe they want to see their granddaughter graduate. They want to dance at their grandson's wedding. Or it could just be that these people are just old and crotchety like you, Paul,
You saying I'm hanging on?
You just a curmudgeon, and I have no doubt that you're here long after I'm gone. Okay, so that's a tough one. Okay, but once again, if you're audited, because you will be, if once that person hits about a year,
or two
or three, they're going to audit you, and you better make sure your documentation shows that when they were admitted, all the certifications were square and they qualified for admission. Things happen. No one can predict when they're going to die. They could die on the second day they're admitted to hospice. They could die 3 years later.
So, the first thing that the government looks at when they either get a tip or a quick tip or whatever is they look at length of stay.
Length of stay is a huge issue for hospice.
That's where they go.
Yeah.
And so you need to, and everybody that's listening to this in hospice, they know that that's the case. They know that's where we're going. So with that in mind, I would recommend, I think that there has to be kind of an audit every 6 months or every year where you recognize that and you update the record.
Or at least quarterly, just because you never know,
And explain why the patient is still on, because you're going to have to explain it. You may have to explain it anyway.
And it's not unusual for people to be discharged from hospice.
That's right. They got better. So
they got better.
You just have to, and as long as your documentation is there, all they can say is we disagree.
Yeah.
If you don't have the documentation,
then you're just milking the system.
And then that's in their view, in the government's view, then you're right.
Yeah. Okay. Now, I'm not going to go over the improper reimbursements or I'm sorry, kickbacks, because it's the same kickbacks as home health agencies. It's the whole problem with independent contractors, with folks that you're paying as employees, but not really employees. Medical director agreements. All those things are a real problem. And if you haven't had, I will say this on medical directors before we move off of that, there have been 2 OIG fraud alerts on medical director agreements. Okay, this is something that they're concerned about. This is something that they're looking at every time they're doing these audits. They want to see the medical director agreements, and then they will cover every time they'll go through, because in the documentation it says who was the referring doc, who was the ordering doc.
Right.
They're going to want to see where are you getting your business from, where are you sending business to.
Because that's easy stuff. So the criminal
shooting fish in a barrel.
Well, the way criminal, I did criminal work, I did civil work. The case that we
done administrative work.
Yeah, that's true.
You argued in front of the Supreme Court.
I did that as well, and got hammered. But
someone's got to lose.
Yeah, but it's my client, not me. But anyway, where were we?
Talking about hospice risk areas.
About hospice risk areas. Oh, what I was going to say is that they're going to be looking at they're looking at two things. For criminal prosecutors like to follow the money.
They do.
That's the thing. They want to see, when I first started doing it, they didn't want to do any healthcare cases unless it involved money. So kickback is easy because it's money. They're seeing you pay the doctor for this, and what did he do for it? You paid you paid someone for this referral. How did you do it? That's the kind of thing that they really can hyper-focus on and will hyper-focus on.
They will. Next slide.
Confessions of an ex-prosecutor.
Now, this is interesting because, these are the last slide and this slide are all hospice risk areas, and they were all identified, okay, going back to 1999. And you could read these and think, well, that's the same problems we have in the industry today.
So it's interesting. One of these that's really interesting, and we'll just talk about a second on, is there's false dating of amendments to medical records. So we'll just take 2 seconds to talk about.
That's an important one.
It's always okay to update a medical record, right?
Yes.
Always. And
in fact, you have an obligation to do that.
Right. What's the problem with a false date, though?
Well, the false date, well, first of all, there's a separate statute that makes that a crime.
Right.
Okay. Falsifying medical records is a criminal violation.
And that's what it'll look like if you make it look like it is contemporaneous when it isn't. They're going to assume bad intent.
And let me just talk about that for a second. These days, 20 years ago it wasn't the case, but these days everything is on EMR. Okay, and it's all electronic. We are now getting audits from the government and from privates where they want not just copies of the electronic medical records. Okay, they also want the underlying metadata so they can go in and actually see when changes were made. Okay, because if they go in and they see, oh, well, you added this stuff before you sent the records into us, then they're going to go after you. Now, what if it's absolute, you should be looking at what you're going to be sending in. But what if you see stuff that's missing? Is there a problem adding?
No, you should. As you say, you're obliged to do it. Just put when you did that.
Put today's date.
And why you add, and if it looks funky, if there's like, ooh, there's something that, put why in.
Right. And we see typos where they left the word not. This person is not positive for X. Okay, we made a mistake. This mistake, when I looked at it, I identified this mistake. I made the correction today.
I read the lab when it came in, but I didn't add that. I wrote edit. I'm adding the actual values of the lab now, but I read that lab when it came in and I know what it was, that kind of thing.
Now, a contract, the problem, of course, is, Paul, when these folks are audited and they're looking at dates of service, they're not looking at something from last month or 6 months ago or maybe even a year ago. It's probably from several years ago, right?
Days gone by.
That's right. And, so the question is, will they give me credit if I correct the record or add something in? Well, they may not. But I would still rather have a complete record than an incomplete record. Think about it this way. If you or your medical director or somebody else hit by a truck tomorrow,
ouch.
If we don't have a complete record on that patient, how is the person picking up that record and that patient going to be able to take care of it?
That is the whole point of the electronic records. One other thing that they do with electronic records is not closing it out.
Oh, that's a huge problem. And why do they do that, Paul?
Well, they want so they can make a late entry.
And because this is really bad, they like to go back and they say, well, once I close it out, I can't go back and copy it and bring it forward to the next.
That's even worse.
That's horrible. Right. That's like the worst thing you could possibly do anyway. Because of course, that's one of the things that DOJ is looking at. I mean, just
cloning.
Cloning is a huge problem.
Right. And cloning is like because you have to do a new exam each time, and the information is going to be pretty much the same. If you don't have those little variances, it's tempting to kind of move it forward, the history particularly, right?
Yep.
So you just got to be careful. But you got to close out the record. And so often we've seen that someone hasn't closed it out for whatever reason. I want to make an addition. Oh, we didn't get to, I want to make sure the labs are in there or whatever. Don't do it. Close it out, add it later, deal with it.
Yeah, put the right date down. Okay, next slide. Now, we've talked about the evolution of the compliance guidance, the voluntary compliance guidance that was put out by OIG from 1998 through 2008. But something happened fairly recently. And understand all of these federal guidances, or all of this guidance that was put out by OIG, it was published in the Federal Register.
Right.
Okay. In 2023, though, OIG said, we're going to shake things up. We're going to do things differently. We're no longer going to be publishing this stuff in the Federal Register. Now we're just going to put it on our website.
Right. And so this, and although they participated in the compliance guidance with HCCA, the one that we referred to earlier, that was not like their sort of official compliance guidance. And so this really talks about how this is going forward. We're going to do this official compliance guidance, and here's how we're going to do it.
Yep. So, what they decided was we're going to issue some general compliance guidance that covers, the waterfront.
Right.
And then we're going to start doing industry updates, which, that's because things have happened in the industry.
And that makes sense because if you read, when you read the 13 or so compliance guidances that they put out between 1998 and 2003 or 5, 85 or 90% of it was going to be the same.
That's
and
right.
so that, it all matters the same. But now they'll just, instead of repeating it, they'll do it industry or provider type by provider type.
So that's really important. So folks, home health and hospice, I have no doubt. In fact, they have, I thought that
it's right under pharmaceutical now.
Okay, it sure is. So hospice is on the current list for them to issue updated guidance on, but they haven't done it yet because I checked the website yesterday. All right, next slide. Now,
but there is general guidance.
There is general guidance that was issued. It's like 90 pages long.
Yeah.
Now, DOJ steps into the breach. Okay. Now, going back a little bit, because like I said, these OIG changes, the recent changes were in 2023, but starting in 2017, DOJ, they were very quiet from 1998 to 2017. There was a time in 2012, I believe, where the antitrust department of DOJ issued some kind of compliance guidance. I didn't cover that in here because it was antitrust. It wasn't really focused on general industries. But in 2017, DOJ said, okay, we expect people to have compliance programs. And whenever there's a problem, one of the first things that they always do is they come to us and they say, look, yeah, we may not be perfect, but we tried our best. We put a compliance program in place, and we think we ought to be given credit for that. We think that ought to be considered before you decide you're going to indict our people or go after us under the False Claims Act.
Right. And so, at first this was mainly the criminal division, right?
Yep.
And the criminal division was doing it in the context of charging decisions. So it was kind of saying, all right, what have you done, and what are you going to do as well, right? If you come up with, if you're, as you say, just having a compliance plan but not doing it is no good. But if you've had one and then it's ongoing, they'll evaluate what you did and how you did it, and then going forward as well.
Uh-huh. So when they first came out with the initial publication that they referred to as the Evaluation of Corporate Compliance Programs, ECCP, there were three primary questions that they wanted answered. The first thing they would do is they would say, is it well designed? And, does that basically cover the 7 elements, and is it tailored to that particular organization? Is it being applied earnestly and in good faith? In other words, is it adequately resourced? So they would actually look at, it's not just enough to have this paper dragon. Have you actually put money and effort into it to try to make sure that you are in fact staying within the 4 corners of the law?
And these questions had like 3 different kind of involved 3 different decisions. One is the charging decision. What would we charge you with? The second was, okay, we're going to have a plea agreement. Well, what's going to be the terms of those plea agreements, right? And then kind of related to that is, what sort of penalties are we going to imply? Or are we going to insist upon?
Yeah. And the third question was, does it work in practice? And under most of these compliance programs, one of the things that you have is you have some kind of internal reporting organization or reporting mechanism so that people can, if there's a problem, they can pick up the hotline, they can send an email in, is it working, basically, is the question. Next slide. All right. So then they came up with the 2017 guidance. It also included 11 basic sections that, they had these 3 primary questions that were going to be answered, but then they would look at these 11 factors or components when they were deciding whether or not it was properly designed, properly financed, and does it actually work.
Did they get paid by the word, you think?
I don't know.
It was 119 questions in 11 different sections.
Yep, it's a lot. And we're going to go through these 11, so we're not going to go through them right now. All right. So then in 2019, 2 years after they issued the initial guidance, they had an update.
Right. And it aligns itself with DOJ's enforcement policies, right?
Yep.
So it makes sure that we're looking at the same things, and it reinforces the need for risk-based, tailored compliance plans, which are fancy ways of saying it's a compliance plan that suits that deals with your risks and your needs and how you deal with them. In other words,
for instance, if you're not a healthcare organization, but just as an example, if you're an international company,
right,
do you have elements in there to make sure that you don't run afoul of the Foreign Corrupt Practices Act?
Right. In other words, so it's tailored. It's not something off the shelf. It is off your shelf.
That's correct. Next slide. All right. Then they came up with a second update.
Yeah.
2 years after the first update.
Do they have a compliance division?
And that update emphasized the use of data analytics and timely remediation. In other words, once you identify a problem, how long did it take you to fix the problem and to take steps to ensure that it didn't happen again?
And it's kind of interesting that at this point they're looking at like managers, third-party management, which is just really starting to take off. These, investment money and mergers and acquisitions, the due diligences, So someone who's looking at, I didn't know. I mean, in other words, they don't want a new operator to say that was under the old. They want due diligence to be, in fact, that true diligence.
Next slide. Then the third update, in 23. They looked at things like compensation structures. These executives in the company, what are their bonuses being based on?
Right.
And they also wanted to make sure that you had a culture of compliance. That was that was kind of the catchphrase of the period, I suppose.
It was, and basically it has to do with having a hotline, encouraging people to use the hotline, encouraging people to be whistleblowers within it, not punishing them and that sort of thing, which is an important thing.
Yep. All right. Next slide. Okay, that's pretty much the same one. Next slide. Okay. Then there's a fourth update in 24, just this time last year. All right. And then they were looking at the use of data and technology, especially artificial intelligence. That's very interesting to me because while this came out in September 2024, if you recall, I think it was February 2024, DOJ came out and said, if we find that you're using artificial intelligence in an effort to help you facilitate fraud, we are going to throw the book at you.
The artificial intelligence issue is really fascinating because I spent a fair amount of time looking at the issues related to AI, and of course the government now, as they're implementing this imposition of review pre-authorizations, they're going to do some limited stuff.
Yep.
And those limited pre-authorizations are going to be based, I have read, on AI.
They are.
So they're bringing in AI, which is like.
But they're saying, but you better be careful you use it.
When you use it.
Yeah.
I thought that was pretty interesting myself.
Next slide. This is just a summary of all the different changes that took place. I did throw in there the antitrust division update. Like I said, they originally had some guidance for the antitrust division that came out in like 2012. I didn't include that one, but this is just a chart that kind of.
We're healthcare lawyers, not
That's
antitrust lawyers.
No, yes. Well, although there is healthcare antitrust, but not that I practice. Next slide. All right. So it really is important. We're going to talk now about those 11 factors that were identified in the very initial set of guidance that DOJ published. And it's important because home health and hospice agencies, you really need to kind of keep up because, if you've got a problem, if you've got a False Claims Act case on the civil side, or they're investigating your home health agency for kickback violations or for other violations, these are the things they're going to be looking at. Next slide.
Now, as we go through these, it seems to me there's a lot of overlap.
There is a lot.
I don't even see that there's 11. There might be 3, but we'll roll through them.
Yeah.
As we'll see, there's a lot of overlap between each of them.
Yeah. The first one, of course, is they want to know about conduct. To the extent that there's been bad conduct that has taken place, what have you done about it? Have you taken disciplinary action against the folks that committed the improper conduct? What caused this? How did this come about? What was the root cause of the misconduct? How did this guy, whoever the bad guy was, how did he get away with this and for how long?
And how do you get there without auditing, which I'm sure is in later, but I mean, again, you can only find out all of these things. You can only determine the root cause if this is like what are the root cause? What is the documentation? You need to have a process to find that. And that goes to I'm sure that
it really does go back to the fundamentals we talked about in the beginning: internal auditing and monitoring. How important that is.
Finding your risk, gap analysis.
Yep.
But there they are. They made it complicated.
And then they want you to document all the steps that you took. Next slide. Okay, senior and middle management. They basically want to know what is the tone at the top. Are people told, look, do whatever you have to do to get the job done? And we'll just turn a blind eye, or are they told whatever you do, you have to stay within the 4 corners of the law?
And this is important in a criminal context because there's when we have layers and you have a C-suite and then below, the C-suite saying, well, we didn't say to do that. There's nothing telling us, and the people below are saying they told us to do that.
Yep.
And so they want actually to know, how does it work? Who's making the decisions? Are there small decisions, large decisions? And so they're interested in that, and with good reason, I think.
Yeah. And once again, they want to know, like, support for compliance. They want to know, did management give the folks in compliance sufficient resources to do their work, to make sure that you're staying within the 4 corners of the law? And that's one thing about compliance that I think it's important to point out. If you're a compliance officer, it's not your job to figure out how to make the company more money,
right,
nor is it your job to figure out how to save the company money. Your sole job is to keep the company within the 4 corners of the law.
That said, you and I both know that compliance and business will often get,
they conflict.
There's going to be conflicts, and it's just a difficult area, but you've got to stand up for where you are in compliance and let the chips fall.
Next slide. Okay, autonomy and resources. This is something that we hear all the time from compliance folks, and that is, when I don't report to the top, and when I tell my boss about it, I'm just beating my head up against a wall.
Right. Well, there is supposed to be a compliance officer. The compliance officer is supposed to have access to the board. Lots of places don't have that sort of board structure.
Yeah, like home health and hospices.
Right. Most of them are smaller. There is that sort of structure, but you are supposed to be independent. And if you're a lawyer and a compliance officer, if you operate as the lawyer and as the compliance officer, as some people still do, it's a very tricky position, and you need to be clear as to when you're acting as one and when you're acting as the other, because otherwise there will be nothing that's confidential.
Next slide. Okay, policies and procedures. They're going to look and see, did you have policies and procedures in place to help you avoid violating whatever risk factor it is that you're concerned about or that has now popped up. Next slide. Risk assessment. Okay, guys, this really kind of goes back to the whole gap analysis that we talked about in the very beginning, and we kind of included those slides that talk about the common risk areas seen in home health agencies and in hospices. But it's important to keep in mind that your organization is different. You're likely to have additional risks that you have to take into account, and you have to make sure that you've identified those risks and you're guarding against them.
And it wants to know how you deal with them when you get them. So in other words, what is the process for someone making not necessarily a complaint, but someone saying this is something that we've done wrong? What is your process? Do you write it down? Do you follow up on it? Where does it go? Does it go to a committee, or does it just going to vanish into thin air? Because you have heard, and I have heard many times, ultimately relators saying, I told them a dozen times and nobody ever listened to me. Well, if they tell you, you need to write it down and you need to deal with it. That's important.
Yeah, and especially for home health and hospice and other healthcare providers, you're going to find, if you're doing your job right, you're doing internal auditing and monitoring, you're going to find mistakes. Keep a record of those mistakes that you find and the money that you paid back, because if there's ever a problem, if you're ever audited, you want to be able to show we're not perfect, but we have systems in place to identify problems, and we have systems in place to pay money back that doesn't belong to us. Good guys do that. Bad guys don't do that.
And a lot of places that I've seen, and I'm sure you've seen too, Robert, where they do kind of mini audits. They're not statistically valid in any way. They're just looking at some claims, and they see some stuff is wrong. If you see something that's blatantly wrong when you do that, don't just pay back those 3 claims. You really have to, at that point, you really need to have a process for saying, I found this, and we're trying to fix it.
Yeah, and as you pointed out, is this a one-off kind of a problem, or is this a problem we've been having for 3 years, and we have to go back and do an internal audit of the past 3 year billings to see how much money we need to pay back?
Because at the end of the day, you're not allowed to keep what isn't yours, right?
That's right.
We used to, years ago, there were some lawyers who advised, well, if they gave it to you, even if it was wrong.
No. Once again, what did Mama say? If it's not yours, give it back. Next slide.
When she would talk to me.
Yeah, training and communication. This really kind of points out, I'm sure the folks that are listening are starting to notice some overlap here between the 7 elements OIG identifies and these. Same thing here, training and communication. This whole process only works if you educate your staff. This is what's required under the law. This is what we have to do to stay clean and make sure that we do this right. And we're going to train you to make sure that you understand what's at stake. Next slide. Incentives. Yeah. Let me see. Confidential reporting. We talked about that. Same thing. This is another one of the things that pops up under OIG 7. They want you to have ways that individuals who are afraid of retaliation can make a confidential report if there's a problem.
This is important. Creating the ability for people to make confidential complaints or reports and to stay anonymous,
such as a hotline.
As a hotline is really important.
Yep. Okay. Next slide. Disciplinary actions. Once again, they want to make sure that you're not incentivizing people to do the wrong thing, and to the extent that people are doing the wrong thing, you better be taking disciplinary action up to and including termination when you find out about it.
That's the thing is, this is a really hard one actually, because they expect discipline something. They expect you to do something when you find wrongdoing, not necessarily firing somebody, but they expect you to chronicle or to identify and keep track of that. Yep. And we don't always like to do that.
9, next slide. Okay, continuous improvement through periodic testing. That's
continuous improvement, really?
Yeah, I mean, they want you to get better and better. I mean, you may have problems now, but those problems, those violations that we identified a year ago, we don't want to make those again.
Right. And I think the periodic testing is, is where we started this, auditing and monitoring. And, you know, you want to keep it, but the thing is, the improvement stuff is tricky because you're going to find, if you do good auditing, you're going to find other new things
Yes.
that you didn't have before.
Yeah.
Not like you're going
Yeah.
to become perfect.
Nobody really wants to turn over rocks because you always find snakes. But if
Right.
you want to be able to get credit with DOJ, you need to be turning over those rocks.
Right.
Next slide. Third-party management. This covers everything from screening. You know, they want you to screen your vendors, agents, and contractors, make sure they haven't been excluded from participation in Medicare. But also, you know, you don't want to be aligned. You don't want to have business partners who are problematic and who engage in wrongdoing.
And this is where they're starting to indicate some concern about when companies get together, are we missing things? Are things falling out of the wayside? Or are they, you know, does that create compliance issues or conflicts that they're not dealing with and that sort of thing?
Yep. Next slide. Now, mergers and acquisitions. This is an interesting one because they're saying essentially, and especially today where we have all the private equity companies buying up all the healthcare companies, DOJ, if they come in and they find problems, it's not an excuse to say, well, we didn't know anything. You know, they're going to say, well, what due diligence did you do when you bought this company to see if they were clean?
And how did you integrate? Did people lose services? Did you know, how did the billing change? What was that integration like? They say they're going to look at it. I'm not so sure. I don't know that I've seen that they have yet, but I think that's an important thing to understand that they might.
Yep. Next slide. This is just excuse me. This is just a summary of those 11 elements again. Just something for you to have. Next slide. You know, the ECCP, just like the compliance plan that hopefully you've got in place, it really is a living, breathing document. You have to, with DOJ especially, every 2 years, they've been updating what they expect of you.
And so the only other thing I would add to this is that there is, you know, the ECCP is criminal. The civil division, you know, has not developed this whole, hasn't been issuing guidance in this way. They do have, in the Justice Manual, they talk about compliance. It lines up pretty well with the elements of the ECCP. The difference would be now that there is the ability to make a self-disclosure to DOJ, they might consider that in the context of what the penalties are and that forth. So all of these things will carry forward through to a civil matter as well, and the civil evaluation. They're looking more at past and prospective, just in the same kind of areas, though.
Yeah. Next slide. Now, just a reminder, we talked earlier in the presentation about how kickbacks are a continuing problem in risk area for home health and hospice. This is just a list of some of the things that you've got to watch out for when you're marketing your services, when you're employing medical directors. You got to be very, very careful about giving anything of value, any type of remuneration to potential referral sources, because remember, there is no de minimis under the criminal anti-kickback statute.
So, you know, this goes to what we were saying before. Follow the money. Okay, this is money going out, and what are you getting in return? Because you can't send money out in direct return for referrals unless they have, under certain circumstances, so on and so forth. So follow that. Between that and length of stay, which is the other.
That cuts out a lot of. If you have a good handle on those issues, that and documentation, you're probably in pretty good shape.
Those are the two. And they involve numbers. We can add up the length.
Yep.
Find an average, that sort of thing.
Next slide. All right. So we're at the end here. Look at your contracts, guys. Look at your leases, your payment arrangements, anybody that you're giving money to, your marketing practices. You check your ownership structure. Screen your people. Make sure. Yes, you're leasing. Make sure that you're not employing anyone, an employee, contractor, or vendor who is excluded from participation in Medicare or Medicaid.
Right.
Okay.
And update your arrangements too, by the way. You know, if you've updated your relationship but not updated the paper to reflect that, that could be problematic.
Absolutely. Yep. Next slide. And that pretty much is an overview. I think we went a couple of minutes over, 5 minutes over or so, but that was pretty good for us.
No questions. You covered everything perfectly.
You have our phone numbers on the very on the face sheet of the presentation, you got our email addresses here and our website here. We're happy to answer questions. Give us a call if we can assist you. Thank you very much.